Hi, my name is Tadeusz Hawrot. I'm also based in Portugal, like a few people here. And I'm leading EFNA's work when it comes to policy and advocacy, both in Europe and globally. Now, the spotlight of this last session will be on Parkinson's disease. And when we think about Parkinson's, we often think about symptoms like tremor and shaking, but this is far from being the whole story. And I'm so delighted that we have today with us Professor Ray Chaudhuri, who is really considered a world leader and pioneering work on non-motor symptoms and non-motor phenotypes of Parkinson's, the symptoms that he called hidden face of Parkinson's. And why it's really important for us as a patient community is that we know that the burden of non-motor symptoms is really something that affects the quality of life for people affected by Parkinson, which is why it's so important of addressing those non-motor problems so that we can improve their quality of life. So it's really great that Professor Chaudhuri does this work. He's, by a mean of brief introduction, he's a professor and consultant neurologist at King's College Hospital in London and the medical director of the Parkinson's Foundation International Center of Excellence, also in King's College, and he has published, correct me, probably around 400 peer-reviewed papers, maybe more, and he will preview to us a talk that he has tomorrow that will look at, let's see, I lost it, gut, oral, and vision health of Parkinson's disease. All right.
Thank you. Thank you very much for this kind introduction. So I think what I would like to focus on tomorrow is based on feedback from patients. Virtually all my research is based on what patients tell us, because as neurologists and researchers, we often forget that the patient's views are very important. And in fact, the non-motor issues which you kindly addressed were mentioned by Dr. Parkinson from London, who described the condition 203 years back. And he mentioned pain, he mentioned sleep problems, he mentioned dribbling of saliva, he mentioned constipation in his patients, which were first described, the condition we now call Parkinson's disease, which I believe is a syndrome. And also worth remembering that this is the fastest growing neurodegenerative disorder in the world. And 1 in 50 of us will get Parkinson's, those who cross the age of 80. And many of us consider this now an epidemic. The number is set to double by 2030. So what is important? I think we've far too long focused on people with Parkinson and addressing their motor symptoms. It's very easy to go to the clinic, alter your levodopa, add a dopamine agonist, see how the tremor is doing, see how the bradykinesia is doing. But what Dr. Parkinson said to us, look below the surface. There is a hidden face. And that's what all my life's work has been. And in this talk, we're going to focus a little bit on what I call the vitals. And this involves vision. We know dopaminergic innervation of the vision is very important. Many people with Parkinson's have difficulty seeing at night. Many people can't read properly, although we give them literature to read, but not ask, can you actually read properly because of the diplopia? Some people have dry eyes, and all they need is artificial tears. We don't ask about that. So vision health, and most importantly, driving. Road traffic accidents have been directly linked to visual health in Parkinson. In addition to the fact people can't sleep or see properly at night, this can lead to falls. Falls leads to fractures. That leads to my second vital, is bones. Osteoporosis is endemic in Parkinson's, particularly female Parkinson patients, but very rarely in our consultation we routinely ask about osteoporosis or get patients screened. All they need is vitamin D, calcium, and in some situations, a relevant prophylactic treatment for bones. So that's the second one. And the third one we'll focus on is gut. Gut meaning the problems of dribbling of saliva. Imagine if you're in a public, if I was dribbling saliva now, talking to you, I wouldn't be here, okay? I would be embarrassed to be here. The reason why many people with Parkinson have social isolation is because they're having problems with dribbling of saliva, problems with speech. Second, dysphagia. Surprisingly common, even in the very early stages of Parkinson. People have difficulty in swallowing. We don't ask about it. Or even if we ask, we don't do much about it. These can be managed. And finally, issues around gut, microbiota, constipation. Simple advice, drink 2 liters of water a day often will sort it out. But we don't do it. And then when I talk about it, people say, oh, I don't have time. My clinics are so busy, I do motor function. But it's actually not true. You can just do a questionnaire, which has been validated, used around the world, translated in 22 languages. The non-motor symptoms questionnaire takes patients 5 minutes to complete. We do it routinely in our patients, and then you have the picture in front of you. Okay, this patient has thick dribbling of saliva, let's address it. So the talk will focus on these vitals. Of course, it includes cognition and pain. I've just described our recent rather shocking data that people with Parkinson's with pain, black Parkinson patients in the UK, are giving half as much analgesia as their white counterparts. Talk about inclusion. So there are all those issues that I think I'll try to bring around and foster a discussion how modern treatment of Parkinson needs to look at the person as a whole, treat the dopaminergic issues, but don't forget the hidden face. That's basically what it is.
Thank you. That's fascinating. And I was wondering, I suppose that among those non-motor symptoms of Parkinson's, there could be some that could be actually treated separately with current existing interventions. Are there any kind of low-hanging fruits here, something that maybe is being missed, but it's important for patients to know?
Yeah, absolutely. I mean, I think the other thing is treatable, these things. And we have actually done a survey across Europe where we found that in consultations, over 50% of consultation never deal with non-motor issues. That's a problem. But they are very relevant. And often the person with Parkinson may not be aware that this is linked to Parkinson unless the doctor asks them. So there are these issues, and low-hanging fruit is, yes, there's management guidelines. I chair the Movement Disorder Society's non-motor study group. We have published our non-motor guidelines, and increasingly the good thing is industry has got more interested. And here, for instance, several trials were presented looking at sleep, looking at pain in Parkinson. And I think this will be the way to go, and there will be management strategies. But there are several issues we can do now. Probiotics for constipation, for instance, large bowel active probiotic. Drinking enough water, 1.5 to 2, it's evidence-based. I'm not making it up. Vision, health by checking vitamin A levels. Check the vitamin D level to make sure that the patient doesn't need vitamin D for bones. This is not rocket science, but it's simple, yet it's crucially important, because if you look at the data, majority of people with Parkinson's fall, have fractures, and then are hospitalized, and they have pneumonia after that, and that kills them. So, it has rather dark undertones, and this needs to be really addressed, I think, in our practice.
And you mentioned that patients sometimes are not aware that certain symptoms are actually those of Parkinson. And I want to touch a bit about early detection, because we are looking at neuroprotective treatments, but when we start them late, it's tricky. And we know that the progression of disease can start 10, 15 years earlier. But there can be some other symptoms that could be visible earlier on, like reduced sense of smell or sleep dysfunctions, and they can begin years before we detect any symptoms. Is there something that you would like to kind of maybe emphasize here in terms of what people should be aware of, so that we could maybe have an earlier diagnosis?
Yeah, I think you've raised a very important point. We were not addressing it tomorrow, but prodromal Parkinson, or early detection of Parkinson, has become the mantra of modern research. In fact, I heard about big data. We are involved in a big EU study looking at an app which might be able to predict the development of Parkinson in normal subjects by combining exactly those things you say, difficult, reduced sense of smell, sleep problems, REM behavior disorder, which is when you enact violent dreams at night, along with speed of typing, volume of your voice, etc. The real question is that even if we are able to predict, what do we do then? Because we don't have satisfactory neuroprotective treatment at the moment. That's one of the biggest challenges we have, and I say to my patients that if I can keep you like this, like you are in 5 years' time, that's a progress. But we can't even do that now. So I think there will be work going, and I'm glad to see there's a lot of prodromal trials going on. Molecules are being developed. And I think the collection of this big data that we're doing with these apps might help predict that. But reduced sense of smell with the REM behavior disorder is probably going to be a key factor where people will have these symptoms and they will then come to us and say, am I going to get Parkinson? And we got to be prepared for that.
Great. I'm aware that we are coming to a close. Let's check if there are any questions from the audience. There seems to be. You would like to add something, Viorica, please? And then I see we also have Orla.
Thank you very much, Professor. I have one question. Considering the list of the symptoms you have just made, osteoporosis, disorders of sleeping, and so on and so forth, it looks as if Parkinson is a disease of the old age. You have also mentioned that it needs to check, the A level, the vitamins, and so on and so forth. If you address, and this is my question, if you timely address those problems, such as osteoporosis, the levels, and so on, blurred vision, is there any possibility that you can alleviate the progress, not to stop, because I understood from the literature that you cannot stop Parkinson. But Parkinson has different, types, aggressive and less aggressive. Right. Is there any way you can alleviate the evolution? Thank you very much.
What a fantastic question.
Thank you very much.
I can speak all day on this, but I'll be brief. So one of the things that has come through and is now a formal recommendation in Parkinson is 150 minutes of exercise a week. Exercise, if anything, and that's bespoke exercise. For instance, I can't tell everybody to go running. Whatever suits your body habit, whatever suits your culture, is very important. For instance, we're doing a trial in the UK, PD ballet, so ballet dancing, how this is improving the quality of life. It's funded by Wellcome Trust. However, if I went to the deep depths of Africa, and I do a lot of work there, I can't go and tell somebody in KwaZulu-Natal, can you do ballet? We have to then adjust that to a dance that is suitable to that particular culture and group. But doing that, now there is formal evidence that there is neuroprotection. So if anything, it's not medicine. It's through our healthy aging lifestyle that might be the solution in future. And your question is absolutely spot on. If we can look at these aspects of wellness, bone health, exercise, diet as well. I didn't speak about diet, high flavonoid diet, for instance. There is good evidence to suggest this might have an effect on our dopamine system and the dopaminergic aging. Whether this will reduce the rate of progression, we don't know, because dopamine loss is an age-related phenomenon, but it does seem to have a beneficial effect which drugs so far has not caused.
Orla, please go ahead.
Thank you. One question with two parts, and apologies if it's a very basic question. Does treatment with levodopa or something similar have a significant positive impact on those syndromic phenotypes that you've outlined? And if it isn't up to scratch in eliminating them or reducing them significantly, is there any evidence to suggest that there is an alternative pathway that could be the root cause of all of those parameters, so vision, oral, gut, etc.?
Yeah, so I think it's a mixed. We're looking at a mixed origin here. There's an aging effect, as he just mentioned. A lot of these things would deteriorate as we age as well our vision, bones, and so on. So you have that age-related decline. Then you have the specific dopaminergic dysfunction of Parkinson's superadded to that. So that this double attack is what's causing the main problem here. And we need to therefore, while levodopa and symptomatic treatment is absolutely crucial, you need to also look at the bigger picture. And that's what the vitals are, which might be a mixture of aging process, but also Parkinson's impact. For instance, we know Parkinson's doesn't only affect the dopaminergic system. Work we've done have shown it affects the cholinergic system as well, right from the beginning. And that can lead to memory issues, but not in all, in a subgroup. So the challenge would be to identify those groups, because in that particular group, you will not be prescribing any anticholinergic drugs. This actually makes them deteriorate faster. So this is how I think we're going to develop subtype-specific medicine. At the same time, the holistic care of bone, vision, gut should be equal for all.
Thank you.
Right, great. Well, I've been really enjoying hearing about your work, Ray, and I have lots of other questions, but I'm afraid I'll have to bring it to the close. So just the last quick one. Where would you see the Parkinson treatment going in the next, say, 5 to 10 years?
Tough one. I think we are going to find good, better quality symptomatic treatment. I think we're going to have good treatment, evidence-based, for managing sleep, for managing pain, for managing vision, gut problems, etc., which we don't have at the moment. And that will make our ability to help the lives of people with Parkinson's and their carers much better, but hopefully some neuroprotection as well. I remain optimistic.
Yeah, great. And again, it's so important to patients, the work you do. Thank you very much. And do you want to mention the time and place of your session tomorrow?
So it's 12:30 tomorrow.
12:30. People can find you somewhere for sure. Okay, 12:30. Thank you.
Thank you.